Okay, everyone. So the purpose of today was really mostly vitamin K, but I kind of had um, some ideas to add, like routine care of the newborn, onto this. Most of that stuff isn't complete, but my vitamin K part is, the purpose is to really try to equip you guys with the knowledge to, like when you encounter a family who is declining vitamin K. As you may or may not have been aware, have been an increasing number of infants coming back to emergency rooms with hemorrhagic disease of the newborn, also known as vitamin K deficiency bleeding. This is really to uh, you know, equip you guys with the ability to maybe turn some of those cases around and convince parents that maybe this is the best um, route to go. There is the slide that is directly from a review from the AAP Committee on fetal medicine that is uh, basically talking points to direct talking points to in order to speak with parents. So make sure you definitely save that slide or look that up. Okay, so and I have the reference and I can tell you where to look that up. So vitamin K is um, very important in the clotting factors produced by the liver. You in medical school, I had to memorize these as factors 2, 7, 9, and 10, and protein CNS. So those are important in that extrinsic pathway of the clotting cascade. And it all kind of works together with platelets as well to eventually form clot. So all the clotting factors here link together in the end to create a cross-linked fibrin clot, and then platelets eventually get into the mix and kind of stick to that clot as well, eventually forming your complete clot. And obviously, this is important in the normal process um, of you know hemostasis and all day every day our blood vessels are continuously injured just by from normal operation, and the this process is important in maintaining um, uh, preventing us from essentially bleeding out, and also obviously from trauma or injury. So um, vitamin K deficiency bleeding, it was originally described by a physician named Townsend in the late 1800s, and it was the vitamin K itself was discovered in 1943, and the AAP published a seminal paper in 1961 that resulted in intramuscular prophylaxis being introduced in 1961. The incidence at that time was around 1 in 400. One study in Cuba found it was 1 in 200. Among infants who don't receive prophylaxis, the incidence is as much as 35 per 100,000 live births, and it is slightly lower, or it is lower in high income countries at 8.8 per thousand live births. Um, Early onset vitamin K deficiency bleeding is generally not able to be um, prevented by IM prophylaxis. It happens within the first 24 hours, especially for mothers who are on medications that affect vitamin K metabolism, such as anti-epileptics, some antibiotics, anti-TB agents, warfarin, obviously. Um, some of the medications are listed below: phenytoin, fosphenytoin, carbamazepine, etc. St. John's wort as well. Um, Cutaneous manifests as a spectrum between cutaneous bruising to life-threatening intracranial hemorrhage. And the IEP found the incidence to be 0.25 to 1.75%. But that number seems kind of high to me because this doesn't seem like something we see often. Notably, prenatal vitamin K supplementation has not been shown to reduce this early onset vitamin K deficiency bleeding. So there is insufficient evidence to recommend prenatal vitamin K supplementation. The classic form usually happens between 2 days and 1 week of life, and most cases are idiopathic. Um, in 1960, there was a study done during a 3-month period where vitamin K was randomized to half of the male infants in the newborn nursery, and the incidence of secondary hemorrhage after circumcision was noted. And hemorrhage was noted to be 6 times more frequent in babies not given vitamin K. In 1967, another study looked at placebo versus 0.1 milligrams of IM vitamin K versus 5 milligrams of IM vitamin K. The incidence of moderate to severe bleeding in the placebo group was significantly higher than either treatment group. Breastfed infants, notably, were shown to be of higher risk than formula-fed infants. The late onset happens between a week and 6 months of age, with a peak incidence between 2 and 8 weeks. It's usually associated with breastfed infants who did not receive prophylaxis at birth. It could also be associated with liver dysfunction for other reasons, biliary atresia, hepatitis, etc. Most commonly, these infants present as intracranial bleeding, and I think that's what we've been seeing more of lately. Estimates from Europe and Asia are between 10.5 to 80 per 1,000 live births, and notably, there are actually no randomized clinical trials evaluating directly the efficacy of postnatal IM vitamin K in eliminating late onset. However, there have been several large surveillance studies looking at the rate of late onset bleeding since vitamin K was introduced in some first world countries noted there, and those show significant reductions in late onset vitamin K deficiency bleeding. So not a direct study looking at the efficacy, but once these measures have been introduced, the incidence of late onset has been reduced dramatically. So, big question for a lot of parents is about oral vitamin K. Yes, it is used in some European countries, but here in the United States, it is not approved by the FDA or the CDC. Okay, the AAP reaffirmed the use of a single IM dose of 0.5 to 1 milligram for all infants, and you'll see over the next few slides that really it takes these oral vitamin K. They're basically regimens over months long time. And if you miss a dose, it might be not as effective, right? It depends on the compliance of the parents. So there was a Dutch surveillance study done in 2005 looking at oral vitamin K at 1 milligram, followed by 25 to 150 micrograms daily for 3 months. And it seemed to reduce the onset of late vitamin K deficiency bleeding from 3.2 to 1.8, but had some overlapping confidence intervals. So we don't know if this result is actually significant. The authors of this study concluded that oral compares poorly to IM vitamin K due to poor parental compliance and non-uniform drug absorption. There was another study done in 2020, as recently as 2020, in Australia. It looked back through 1993 to 2017. There were 58 cases of vitamin K deficiency bleeding. 91% of them were exclusively breastfed. 7 of those cases did receive oral vitamin K, but the majority did, and the majority of that did not receive all 3 recommended oral doses. There was a time in Australia where oral vitamin K was recommended from 1993 to 1994. The vitamin K deficiency bleeding rates were significantly higher during that time. In 33% of these cases, vitamin K was not given at all, primarily due to parental refusal. And the Australian National Health, their governing body for their basically like our CDC, considers 1 milligram of vitamin K gold standard. There was another Swiss pediatric surveillance study looking at 2 doses of 2 milligrams of oral vitamin K, and it only resulted in a modest decrease in late vitamin K bleeding, deficiency bleeding. So the regimen was increased to 3 doses of 2 milligrams each. This might place, hold on. I think my point here is that there really hasn't been an established regimen or dose of oral vitamin K. Um, it can be unreliable in terms of patient compliance, as well as we don't know what the gold standard, like the right dose of oral vitamin K is. And if we know that one IM dose of vitamin K decreases the chance of late onset bleeding, then that is the easier choice. So parental refusal. So it's usually in 3 categories, due to their belief systems, due to their concern for their infant's welfare, and outside influences. The reasons are usually a lack of understanding, belief it's unnecessary, concern about the preservative, although there is no evidence that the small amount of benzyl alcohol is associated with toxicity. The Board Network did a study from 2017 looking at 102,000 live births from 35 sites. 638 families refused IM vitamin K. Exclusive breastfeeding, non-Hispanic white race, female infant, greater gestational age, increased maternal age were significantly associated with refusal, as well as the desire for a natural birth. It was also associated with denial or refusal of ocular prophylaxis and Hep B vaccine. In New Zealand, a survey looked at reasons for vitamin K refusal or non-administration of vitamin K among healthcare professionals. 100% of physicians versus 71% of midwives believed that vitamin K was important. They believed that it was important that infants receive a dose of vitamin K. Delivery outside the hospital is also associated with refusal. Some myths that should be debunked. You may hear in the media or otherwise, or social media, that vitamin K, there's some link between vitamin K and childhood cancer. There have been multiple studies that have debunked this risk. So one paper from, I forget, a journal. I forget what the full name of that journal is, but they performed an analysis of individual patient data from 6 case control studies. There was no evidence that IM vitamin K was associated with childhood leukemia. And actually, suboptimal vitamin K status may actually be associated with increased risk for chronic disease. And a high dietary vitamin K intake has been linked to reductions in cancer mortality and incidence. And this was the supplemental information sheet that I was talking about. This is from a review from the AAP from 2018 or 19 that has some good talking points on, basically to put in your back pocket to be able to talk to parents about this. I've heard the phrase sometimes, we're going to give vitamin K to make your baby clot better. Well, that kind of doesn't give me a frame of reference. Is their clotting ability already normal and we're boosting it? Is there something wrong with my infant? I think if you're going to say something like that, you got to give it in context, right? So, few of the talking points here. Okay, vitamin K is used by the body to form clots and to prevent bleeding. Babies are born with very little vitamin K in their bodies. Vitamin K does not cross the placenta, and levels are low in breast milk. It takes infants months to achieve sufficient vitamin K levels to prevent bleeding. For 60 years in the United States, we've been giving newborns a one-time shot of vitamin K to prevent bleeding. Babies who do not receive vitamin K shot are 80 times more likely to have a severe bleed. The most common site of severe bleeding is in the brain. 1 in 5 babies who have a serious bleeding event from vitamin K deficiency will die. Bleeding from vitamin K deficiency is a risk during the first 6 months of life. Vitamin K deficiency bleeding is now rare, and you may have never heard of it because most infants receive the shot. Vitamin K is not a vaccine. Vitamin K injection does not contain mercury. Vitamin K does not cause cancer. And you have the kind of the evidence from the previous slides. The vitamin K injection used in newborns is safe. The dose is not too high for newborns. Oral vitamin K is not as effective as a shot and must be given repeatedly over several months to be effective. There is no oral vitamin K product approved by the FDA for newborns. The momentary pain of vitamin K shot can be lessened by holding the infant in breastfeeding. The AAP recommends that every newborn receive a one-time vitamin K shot at birth to prevent life-threatening complications and bleeding that may follow. So I've been talking for a while. I didn't really pause to answer questions there, but any questions from any of that I just talked about?
Hey, Eric, I just going to chime in and just say that if there's any family where it is the preservative that they are worried about for vitamin K, we do have preservative-free vitamin K in the NICU. We do not advertise this, but for a family that wants preservative-free, you guys can use it on them.
I should add that in there. Yep. May have been, was that too heavy on like the evidence part? Everyone?
No, that's good. The other thing is to also just to let everyone on this call know that there was a baby at Fairfax within the last couple of months that actually was admitted with a brain bleed from vitamin K not being given. So it is not common, but it happens, and we are working on a system-wide refusal form where it will clearly delineate death and or severe brain damage from a bleed. You know, sometimes there are worse things in life than the death, and parents have to know this.
Hey, Dr. Goldberg. So I did also hear that Peds Hematology is offering consults prenatally to mothers who may refuse vitamin K or are known to maybe in the future refuse it prenatally. Do the OB docs know that? Do they know that that resource is available?
Is it available for them to talk to our patients too?
I would think so. I mean, they're within the Inova system. So
I don't know. I have not heard that. We have not brought that up on any OB department meeting.
Just to follow up on that, as far as like the availability of the preservative free, I've had multiple patients, agree to vitamin K if it's the preservative free, but the chain of getting it on the nursing side is very difficult because we don't have it on the L&D unit. I know it's stocked on NICU, but most of the pharmacists have no idea that that's even an option or having trouble like putting in the order or like tubing it to us. There's a whole like chain issue for getting it from like the L&D side point. So I don't know how we can like make that a little bit more streamlined or even stock it on labor and delivery as an option to make it a little bit easier for us to administer that.
You certainly can talk to pharmacy. I know that it's much more expensive. They did not want to offer it to every single parent. And we had talked about stocking it there, but there are expiration dates on it. So, I mean, you certainly can call down the pharmacy. They should all know about it since we are well stocked with it. And if at any point, just call up here and we're happy to bring it down and give a dose to you guys.
Cool. Yeah, so maybe I can email this supplemental information sheet to Rachel so that she can disseminate it to everyone. I'll take care of that. Anyway, so any more questions before I move on? There are just a couple of more topics here. Okay. All right. So Hepatitis B vaccine. Hepatitis B vaccine is the most effective method to prevent hepatitis B transmission. We give it to all our full-term infants, and for preterm, the usual numbers are 2 kilograms, day of life 30, or discharge whatever is first. Okay. If mom is Hep B positive, the baby needs both Hep B vaccine and HBIG within 12 hours at different intramuscular sites. If less than 2 kilograms, this immunization does not count on their typical hepatitis B 3-dose schedule. Okay. Hep B vaccine is 75 to 95% effective in preventing transmission if given it less than 24 hours. If you add in HBIG in there, that adds another 0.7 to 1.1% of that. The Immunization Action Coalition reported greater than 500 hepatitis B history errors from 1999 to 2002. Either there was no maternal hepatitis B surface antigen result, it was misinterpreted, it was falsely negative, or even reported to the care team incorrectly. Okay, the hepatitis B vaccine is the safety net for situations like that. Okay. These are a couple slides borrowed from my prenatal labs talk. Jaundice, what to tell parents? It's very common. 60% of term infants and 80% of preterm infants develop jaundice in the first week. Now this is data from before the new hyperbilirubinemia guidelines. So it might be even a little bit less than this, probably is. Bilirubin is a product of a recycling of red blood cells. In utero, the maternal liver takes care of the fetus's bilirubin. Newborns develop jaundice because they recycle red blood cells faster, 2 to 3 times faster than adults. The chemical processing of bilirubin by the infant's liver is not yet mature, and there are other reasons too, such as enhanced intrahepatic circulation or decreased intestinal flora, but the numbers 1 and 2 there are the most important reasons. When we see Coombs positive, when an infant is Coombs positive, what does that mean? It means that mom has created an antibody against the certain protein on the infant's red blood cells. This is basically alloimmune hemolytic disease of the newborn. So it's destruction of the fetal and neonatal red blood cells by maternal IgG antibodies, namely the FC component of the IgG 1 and 3. The major blood groups we usually talk about are Rh and ABO, but there are many that we have discovered, such as KEL, Duffy, MNS, P, E, etc. And KEL has become much more important nowadays, now that we have Rogan. So how does maternal sensitization happen? Either by fetal maternal hemorrhage, a prior transfusion that the mom received even prior to being pregnant, previous pregnancy or miscarriage, or antibodies developed against even infectious diseases or other antigens. So like a viral infection can precipitate mom to create an antibody against like A, B, or etc. That's too much to go through there, that table. Okay. Rh hemolytic disease, anti-D is most severe and most common. It's generally extravascular hemolysis. The Rh antigens are located on chromosome 1. It's becoming less and less common with prenatal care. Anti-C and anti-E and anti-KEL are emerging as much more frequent. All right, so just kind of a graphical representation of what happens. So let's say mom is Rh negative and dad has the Rh antigen on his red blood cell. During pregnancy, the baby has inherited his father's Rh positivity, his or her, and some kind of fetal maternal hemorrhage happens, or even again, like I said, like some viral infection before the pregnancy, or even food antigens, I think, can also cause mom to develop antibodies against the fetal red blood cells. And these antigens enter the mom's the bloodstream, and she creates antibodies. Those antibodies, especially the IgG ones in particular, cross the placenta and attack the fetus's red blood cells. As much as 0.1 to 1 ml of B positive red cells is enough to trigger a maternal antibody production. Assuming no antenatal or postnatal treatment, the natural RH course is 14% stillbirth, 23.8% neonatal death, and 7.2% kernicterus. Following 2 doses of RhoGAM at 28 weeks and within 72 hours postpartum, RH alloimmunization can be reduced to less than 1%. And if you're looking at the surface of the red blood cell, basically this is a graphical representation of which antigens are kind of where. So, these antigens are kind of sticking out on the red blood cell, like the lock and key mechanism, the antibodies that mom creates attach to those antigens on the red blood cell and eventually cause hemolysis, attack the cell and cause hemolysis. And as you can see, there's many, many, many different proteins on the surface of the red blood cell that the mom can create antibodies against. ABO hemolytic disease. This happens when an O mother delivers A or B babies. Happens 15% of the time. 3% of pregnancies result in ABO disease, I believe. So hemolysis is more common with anti-A, apparently. Okay, so actually I thought it was B. Actually, I thought it was B. Anti-A and anti-B are naturally occurring antigens. Blood type A expresses anti-B and vice versa, but usually it's IgM, so the IgM does not cross the placenta. It's severe in as much as 1%, and exchange transfusion is required in less than 0.1%. And there are also minor blood groups, Kell, Duffy, MNS, and P antigen, even many more than that, as you saw earlier. And Kell is actually the first erythroid-specific antigen known to be expressed during development. And anti-Kell antibody only in 0.1% of pregnant women. So bilirubin neurotoxicity, kernicterus. How often does that occur? 0.1 to 1.3 per 1,000 live births. Should be considered if serum bilirubin is around 25, sometimes even less than 25, if the infant is symptomatic, and if lower, especially if infant is preterm. It can start with poor suck, hypotonia, lethargy, jitteriness, but it can progress to more severe symptoms such as retrocolitis, hypertonia, opisthotonos, seizures, apnea, possibly death. Phase 1 is reversible, whereas 2 and 3 may be reversible depending on timing. There are lots of long-term effects. It's not just the cerebral palsy, as you may hear, chorioathetoid cerebral palsy. There could also be sensory neural hearing loss, subtle cases with auditory, learning, behavioral, and even psychiatric disorders as well. And when phototherapy occurs, why does only blue light work specifically? So I kind of think of it like this. So if you remember from chemistry or physics, when electrons are in a certain energy level of orbit around atoms, right? So it takes specific energy levels to make an electron, let's say, orbiting a hydrogen atom. You need a specific wavelength of energy to make that electron jump to another energy level. What is what makes chemical bonds? Essentially electrons, right? So when you have a specific wavelength, in this case for the jaundice molecule, 460 to 490 nanometers, that's in the visible wavelength, it turns out to be blue light, right? So this blue light is the correct energy level to change up some of these electron orbits and shift these chemical bonds and isomerize them into a form, a bilirubin form that is able to be urinated out. It becomes water soluble. So that's essentially why it's blue light. Sometimes I hear people say it's UV light or it's infrared. No, it's none of those things. It's blue visible light. Okay. So yeah, that was just some science stuff, geeky science stuff. So the importance of metabolic screening. I wanted to get into this a little more. I didn't have time to get too into this, but the metabolic screens for, I think in Virginia, 35 specific disorders, from genetic to metabolic, etc. And they do a hemoglobin electrophoresis too. This is just some of the resources from the Commonwealth of Virginia that you can use. I don't know if this is what parents get here or not, but you guys can look into this. Importance of hearing screening. Bilateral hearing loss is the most common congenital disorder. Happens in 1.7 per thousand babies. Genetic causes are estimated to be 50%. Intrauterine infection, especially congenital CMV, is attributed to be 30%. So that's an early detection of hearing impairment is associated with improved developmental outcomes. Here. Importance of congenital heart disease screening. The congenital heart disease prevalence is 1%, and 25% of these will have critical congenital heart disease. 33% of infants with congenital heart disease are asymptomatic in the first few days of life, as the timing of presentation may be dependent on the patency of the ductus arteriosus. Early detection of congenital heart disease has been shown to improve infant morbidity and mortality, so universal screening was adopted in 2011. Other important interventions we do, erythromycin or 1% tetracycline, we use erythromycin. Notably, this decreases the incidence of gonorrhea conjunctivitis, but not chlamydia, okay? One thing to note, does not prevent chlamydia, okay? I wanted to add more to this later, like Carsey challenge and stuff, but that'll be for another time. I think this is a little bit long too. We're at 33 slides now, so maybe in the future I'll kind of cut this in half. But yeah, that's all I have for today. But the main focus of the talk was vitamin K. Yeah, does anyone have any questions? Anyone? Yeah, the really important thing will be that supplemental information sheet that I had earlier. Get back to. But Rachel, I guess I'll send out some questions maybe next week or so.
Sure, absolutely.
Cool.
And Dr. Lee, while you're on the call, Dr. Lee, do you mind just quickly reviewing about tongue tie and how it's, the provider's diagnosis? Thank you.
Yes, maybe that's something I should add to the talk too, but it's been an issue at times where a tongue tie is noticed and maybe the parents are kind of informed about it, not from a provider, not from a physician, and they get anxious about it, and it's not necessarily a cut and dry thing. Oh, you have a tongue tie, you need to have a frenectomy. That's not the case. So it's important that physicians or a provider make the diagnosis of that. And I think if you see one, even if you see one, right? So it's not a given that infant's going to have problems. It's not a given that infant's going to have issues latching. It's not a given that the mom's going to have pain breastfeeding. So I think it's something to notify the provider about. And I think the lactation consultants, we're going to talk to you guys about maybe putting a keynote in the front of the patient's chart, and so that the provider is aware, or informing the provider, so that the provider can do the physical examination and do the counseling appropriately. There is a kind of I don't know if I sent out a podcast about I don't know if I sent it to you guys, but I sent it to the lactation consultants about there was a case in New York where there was publicized I don't think it was a hemorrhage case, but it was something about a mom went to the paper. The infant got a frenectomy, may or may not have needed it. I think had developed behavioral problems later. Was that associated with that procedure or not? It was publicized in a major newspaper, and I think there have also been cases of infants who have exsanguinated because of improper frenectomies done by non-physicians. So, I think that this is something that is not just a willy-nilly, oh, kid has a tongue tie, needs to be cut kind of thing. We need to be more careful about this, about informing parents about it. So if you notice the infant has a tongue tie, I would just put it in a sticky note or inform the provider. And this is subjective too. So, an infant family might go to an ENT or a physician, and they might not think it needs a tongue tie or a frenectomy as well. So it's definitely not a cut and dry. Even in the literature, it is not cut and dry whether or not frenectomy should be done. Was that kind of what you were, Rachel? Or?
Yes, thank you.
Cool. All right, 38 minutes, not bad, right?
Nice talk, Dr. Lee.
Thank you.
Anybody have any other questions about vitamin K, routine newborn care?
Thank you, Dr.
This was
Lee.
very educational. We appreciate it.
Thank you, everybody.
Thank you.
Thank you, Dr. Lee.